So good morning, everyone. I'm John Fitzpatrick. I help to organize these meetings on behalf of KC Digital Drive. I'm mostly a volunteer to the organization. I have a practice of my own in strategic business development and global affairs. I have ended up being hyper-local, though, recent times, helping local companies with various different strategies and business arrangements. I'd like to kind of go around the room, so to speak, and get everybody introduced. That's been kind of our habit since we've been meeting in live circumstances or in-person, on-site circumstances. And I'd like to kind of keep that up and have everyone introduce themselves. Jim, can I start with you, please?
Sure. I'm Jim Sarsov. I'm the program manager with the Solutions Lab at KC Digital Drive.
Scott?
Did you say Scott?
Uh-huh.
I'm Scott Gunnagle with MetaView. I live here in Kansas City. We're a mixed reality image guidance point of care ultrasound incubation company.
Great, Todd.
Todd Ike, On and On. We do 3D mapping.
Hannah?
Hi, I'm with Modern Health. We do a couple different things, but I work on our virtual critical care side of things.
Oh, welcome. Glad to have you with us.
Thanks.
Anurag.
Morning, my name is Anurag. I'm here with the health innovation team at Digital Drive, but also have a company called Health. We do health information security as well as health analytics.
Thanks. Ashley.
Hey, I'm Ashley Smith. I'm a clinical informatics nurse at North Kansas City Hospital.
Bob?
Hello. I just started a couple of weeks ago with a group that's related to Cable Television Laboratories, which is the R&D organization for cable in the entire world. And SCTE is a standards development organization aligned with ANSI. And I'm charged with technology innovation and strategy, and some of the areas related to what I'm doing in this group is telemedicine, aging in place, but there's also immersive experiences, VR, AR, AI, machine learning. There's a lot of areas, and they're just trying to advance some of the possibilities. And I think there's some ways for interplay in this group, and then I want to make sure you all know there's a innovation10g.com is a contest that has some pretty good money and extremely good notoriety for groups to participate in for getting on stage and getting around some sea levels. So that's it. Thanks.
Great. Thanks, Bob. Sean Brown.
Good morning, everyone. I'm Sean Brown, and I am a program officer at the Kansas Health Foundation. And sometimes my internet is unstable, so if I turn my video off, that's why. Thanks.
Welcome, Sean. Just to let everybody know that Sean will be one of our panelists next month in the March meeting as we have the health foundations in the area speak to their views of innovation and technology and so forth. So welcome, Sean. Daniel.
Guys, I'm Daniel Kennedy. I'm the Vice President at BioNexus. And there's going to be construction going on behind me as well throughout the day. So I'm going to be also in and out on video. But this is my second meeting, and it's really good. I know I've made a number of one-on-one connections from the first one. So I'm very excited to be back again.
Great, welcome. Derek.
This is my first meeting. I'm Derek, and I'm heading up an open source free project called Corpusum, which is medical graphics, interactive 3D graphics. And that project's been going for about a year, but about 3 months of actual development. So I'm here looking for potential use cases, really.
Okay, great.
Networking, of course. So,
are you Kansas City based?
I am. I'm in Overland Park.
Okay, great. Welcome. Doug.
Sorry about that. I'm Doug Hohulin. I'm doing consulting work for XR Technology, specifically around the healthcare field.
Thanks, Doug. Franklin. Franklin, are you with us?
Oh, can you hear me?
Yeah, now we can, yes.
I'm a KU student. I'm just here to learn a little bit. So that's why I got into this meeting was I found it and want to learn and listen to your panels. So I'm nobody in tech. I'm just in KU as a IT student at the graduate level. So
don't worry, you're very welcome here. So
thank
great,
you.
Great you're with us.
Thank you.
Greg.
Good morning, Greg Elliott with 1623 Farnham. I'm based here in Kansas City. Our data center's up in Omaha, but super involved in all things tech and in the region, from AR to VR to anything with high bandwidth usage and large data amounts we're certainly interested in. So that's my story.
Great. Jenny.
Sorry, I'm at Children's Mercy and I'm in the open areas. I have my mask on. I'm Jenny Marshall. Sorry, I'm Jenny Marshall. Can you hear me now? Okay. So sorry. So I work at Children's Mercy and I'm in an open area at the moment. So that's why I have to have my mask on. But I am the Director of Feasibility and Strategic Outcomes for the Department of Strategic Planning. I help a lot with remote health, and I also work with all the different groups within the hospital on some of their tech and getting their items to fruition. So I'm interested to hear about what we have to say today.
Well, and it's good because we have a children's presentation, which is very welcome. So thank you. Liz.
Hi, I'm Liz Cook. I'm the telemedicine clinical manager at Children's Mercy.
Great, thanks. Lucia.
Hi, my name is Lucia. I'm the Associate Director for Social Determinants of Health for United Healthcare, one of the Medicaid plans in the state of Kansas.
Great, thanks, Lucia. Molly.
Morning, everyone. I am Molly Brown, the Program Director for the Heartland Telehealth Resource Center, and our center works with Kansas, Missouri, and Oklahoma.
Great. Robert.
Hi, so I'm Robert Stiles. I used to say I was with HTRC. I still do some with them, but it's been now more as the program director for a number of federal grants, HRSA and SAMHSA, related to the telehealth training center for the country. We have an evidence-based telehealth network grant that does a lot of behavioral health and school-based work, and moving into use of telehealth with community health workers and social determinants of health. And then we have a SAMHSA grant related to disaster preparedness and recovery using telehealth and other techniques. So glad to have Molly on board so I can move into my other role, actually running all those wonderful programs.
Well, that's great. We look forward to maybe having you present those to us at some point in the near future. Ryan.
Good morning, Ryan Allenbrand also with Children's Mercy Environmental Health. I'm our program manager, environmental hygienist. I would say what I say to families, I'm a ghostbuster, if you will, the indoor air quality. So I'm going to talk to you today about kind of what we do at Children's Mercy.
Great. Well, very welcome to you, Ryan. Thank you. Sean Patel.
Sean, did you say my name?
Yes, I did.
Great. It's great to meet everyone. My name is Sean. I'm the CEO and co-founder of REACT Neuro, digital health company based in Boston using virtual reality, and look forward to sharing a little bit more about it today.
Great. Thanks for being with us. Stan?
Stan Edovich, semi-retired faculty from both medical schools, known for real-world evidence and pharmaceutical safety, working locally with Heart to Heart.
Great, thanks, Stan. Is there anybody that I've missed? Great, I'm sure we'll have a few more stop along. I know that Aaron is waiting. We've got several others that I'll just get joined right now. Hi, several folks just joined us and we were just completing introductions, and so you got to us just in time. I was wondering if you go ahead and quickly introduce yourselves, William.
Hi, everyone. William Crumpler, works as Digital Inclusion Program Coordinator with KC Digital Drive.
Thanks, William. Steve?
Steve Kropp with University of Kansas Health System.
And Paul?
Joining in here. Hi, Paul Bashor. I'm with Mid-America Regional Council as a data developer analyst.
Great, welcome. Okay. Looks like we've got everybody in for now. That's a great sign for us to get started. I'd like to introduce our first presenter is Ryan Allenbrand from Children's Mercy. He's the program manager for Children's Mercy Healthy Homes program. And as many of you know, Children's Mercy is really nationally recognized for its environmental health program. And we've had several of their shining lights present to us before. And Ryan is continuing that process and showing us kind of their latest innovation, and that is to be able to do virtual home visual assessments. And so I'll turn it over to Ryan.
All right, thanks, John. First off, I apologize for my voice, and also my internet may be a little silly today, so heads up on that. Let me share my screen here with you all. So one moment, please. Can you see my screen?
Not yet.
Not yet? Okay. Okay.
There we go.
Let's try that.
That's it.
Excuse me.
Mm-hmm.
All right. So, yeah, so today I'm going to talk to you about our virtual assessment process. Like I'm sure many folks here, our world changed after COVID hit, and the way we were able to serve the families that we've served for almost 20 years changed drastically. You know, families started to they were uncomfortable with us coming to their homes, obviously, and we didn't really have a mechanism in place to provide a safe home visit, because, you know, we didn't really know what was going on and what the next steps were. So I'll go through some of those steps today. I'm going to kind of set the scene or the stage, if you will, about our program and kind of why we do what we do, and then get into the virtual home visits. So we, of course, we have a couple of different hospitals, one downtown Kansas City and one out here in Kansas, and quite a few clinics that have popped up over the years around the state of Kansas. We work with a variety of different groups within our hospital. I know there's a couple folks on the call that we've worked with in the past with strategic planning and whatnot. And I wear a variety of different hats. One's kind of a social worker hat, and, you know, just trying to find families additional resources along the way. So we provide a in-depth, comprehensive visit to families. Can you see that I'm moving my slide forward here? Okay. Okay.
Yeah, we're good.
So excellent. So we provide an in-depth visit, and a lot of this is based off of the family's, the child's health. It's really determined, you know, what potential exposures they may be dealing with in the home, and what the health outcomes have been for this child over the last year or so. So we do a lot of prep work prior to even calling the family. We'll get referrals for a variety of different health situations. We basically started with asthma years ago in allergy, asthma, immunology department, and we're currently in pharmacology, toxicology. A lot of that is based off of exposure risk, whether it's lead poisoning or mold or chemicals. So we kind of see it all. And so we've expanded our repertoire, if you will, over the years, not just for asthma, but for immunocompromised children. So we get a lot of variety of different calls, and we've performed a lot of home visits, in-person home visits over the last 20 years, and now we're kind of doing a mixed bag of virtual and in-home visits. We're part of the PACU, or Pediatric Environmental Health Specialty Unit. We are the Midwest region, or the center within our 4-state region here in Nebraska, Iowa, Missouri, and Kansas. So our medical director, Dr. Friedman, is our director for the PACU here, or the MAP PACU is what we call it. And so we do have some funding to help some families out, or some training. There's a variety of ways we can use some of that funding to help reduce some of the exposures that we might see within homes and where kids learn and play. So as I mentioned, kind of setting the stage here of kind of why we do what we do, we do get a lot of calls about mold. You know, the mold that's growing in my bathroom. It's killing my family. There's a lot of worry about mold. And I would say a lot of what we do is, of course, we kind of validate some of those concerns. Wearing that social worker hat, but we also come in and hopefully provide some good guidance along the way that, maybe it's not as big of a deal as you thought, but we see all these other issues besides moisture. There's pests, there's families smoking around the child. There's all these other exposures that we do consult on, but we know there is a concern about moisture and chronic damp conditions, and we do see this quite a bit, and the research is very clear about how there is that connection between respiratory health and damp indoor conditions. We also know, and as we continue to do what we do, we do write papers year after year, and a lot of data that we collect, whether it's particle data, and there's a lot of different things within particles, within settled dust, whether they're indoor chemicals that we're using, stuff we're bringing in from outside. And so we know these exposures exist, but we don't know what that really looks like. So we do, as I mentioned, sort of the Ghostbuster thing. We do measure for a lot of these particulates at different levels, and visually look at the home and see, what are those potential risks within the home environment. And a lot of what we're doing, just regular kids bouncing around their homes, we're stirring up dust, and most time we don't know what's in that dust. So again, we provide some guidance on how to reduce some of those exposures over time. So there's a variety of different ways we receive referrals. Most often they come through our own physicians, nurse practitioners, through our own system. We do get sort of some cold calls or family self-referrals. Outside medical providers will call us and say, hey, we've got this this child that is their asthma is not controlled. Can you help them? We're concerned about mold in the home. That's a pretty common theme there. So we do provide a lot of case management over time, and provide a lot of feedback back to not only the family about how to hopefully effectively address the situation, but also back to the provider, because we're kind of the eyes and ears of the physicians. A lot of what we do is part of community benefit, providing that benefit to our metro and to those families that we serve. And as money and grants allow, we try to support what we do, whether it's what you'll see here in a minute, the Healthy Home Kits that we provide to families, which is sort of an intervention, but also minor home repair, which we've had a chance to do over the years. At the beginning, we try to figure out what those challenges are with children that have asthma. Just as one example, this is the asthma control test, a validated test that we ask each family that we work with to kind of gauge what the level where their asthma is right now. You know, is it controlled? Is it not controlled? Does it seem okay? And then we also base that off of some environmental questions that we ask, which is this: tell us about your home, which goes through some simple questions that we can email the family. We can go over the phone with them. You know, how often they're cleaning, do they have carpet in the home, how old their home is, do they have moisture issues? If so, how often, within the last, as soon as the last week, or within the last 6 months, or maybe they're not sure. A lot of families don't really know, you know, some of these questions, you know, answers to these questions until we start performing the home assessment. Of course, as I mentioned, everything sort of looked different before COVID, and the way we provided our service was different. We would go out to homes, we'd get the calls, we'd do our case review of each referral, and then we'd decide whether a home assessment was warranted. For those that were, we'd go out to the homes, and our flow chart here looked a little different. Now a lot of what we're doing is online consultation, and we'll talk about some of the strengths and weaknesses that we've seen over the last year and a half with that. But this is just one example of our low risk flow charts, our touches or connections with the family over time. And this will look different depending on the health utilization. So the acute care visits, how often they're going to the doctor, how many inpatient stays, how many emergency department visits that they've had. So as we've continued to learn, we've kind of adjusted along the way how we're doing our virtual visits. At the beginning, I sought out friends and colleagues across the country to say, hey, do you mind doing a virtual visit with us? We're trying to learn about this. We worked with our telemedicine group at the hospital to basically build our procedures for performing these virtual visits. And so as we're learning, each visit's a little different. The lighting can be really good or it can be really bad. And so we do provide a lot of guidance, even at the beginning, before we even step into a virtual meeting like this with a family, these are some things we would like you to try to do. And, make sure you charge your phone if you're using your phone as sort of the main device for the virtual visits, just as one example. But also thinking about, as the provider, as the clinician, what does our background look like? Do we have kids running around, like crazy in our background? What's the, how, what the other noise or the other potential distractions might be. So it's something that we've had to adjust over time and really think about. And these are just some other examples of some etiquette, trying to be on time and, making sure your space isn't cluttered, being professional, trying to look nice, that kind of thing. You might be wearing shorts underneath, that's fine. We see that, right? But you might have a tie or business casual on top, and that's okay. But also, trying to engage your client. And that's something that I've seen. And I'll talk about the strengths and weaknesses, but I've really seen a difference because I've been in at the hospital for about 18 years now. And I think the engagement is really different. And it's in a way, it's a positive. And, there's this barrier between, us and the client. So there's some safety there. And, a lot of times as we were going into homes, and we're still kind of doing that on case by case and as things open up, but I think there's a sense of security in a way. But there's also, as we're going into homes, there's a lot of judgment. These strangers coming into my home, they're judging me, and they're gonna think I'm a slob or whatever. So we try to set the stage, whether we're doing this virtually or in person, to let families know we're here to help and not to make those judgments. All right. So as I mentioned, we've developed this procedure, and we have a variety of different touches, up to about 5 touches here in our checklist that we, and the way we designed this really was, and I know somebody mentioned earlier, was community health workers. That's something that we felt like this would be a really good and simple tool for community health workers to use. And right now, we have just Anita Didana, who's our community health specialist and asthma educator, and myself. And that's kind of our team for homes right now. We're down 4 people since the pandemic hit, unfortunately. So as we build this out, and we actually received a HUD grant and some additional dollars to help families, we're going to build this program out even more and reach out to community health workers within our hospital or higher, and this is going to be a really good tool for them to use. And so as we're beginning the conversations with the families that we're serving, again, we're doing a lot of this online. We're emailing families. As you may imagine, we work with all different ethnicities of families, and English isn't always their first language. And so we've been fortunate over the years to have interpreters, and that's changed a little bit. And maybe those that are at Children's Mercy that are on the call, they kind of know that too. And so we contract with a different group nowadays, but we still have the availability to use interpreters. I was at a home the other day where I had my phone and my Surface Pro, and I was able to quickly pull up an interpreter to go through a report with the family. So we've been really lucky there. And so as we're communicating with the family, we're doing a lot of that upfront research on the child's health and what those exposures look like. And so once we decide that we're going to do a home visit, for the virtual visits, we're going to do a walkthrough. In-person visits, we're doing a walkthrough. We're asking the families to take us around to the spaces that the child spends most of their time: bedroom, bathroom, living room, kitchen, basement if they have one, playrooms, other common spaces. And honestly, most of the house is what we're assessing. Yeah, even nowadays. And so, but one thing that I have seen with the virtual visit model is I feel like there's spaces that families purposely don't take us in. Maybe before they felt like, as in doing in-person visits, that they had to take us in, but now they're, I think, a little more, I don't know, say direct, maybe about like, well, we don't really need to go into that room. Well, that's fine. This is, of course, this is all voluntary. Just, we would just want to see those main spaces. But we also talk about how, the shared air in the home and how whatever is going on in one bedroom could affect the rest of the house. So we do try to educate the family on that. So as we're doing this walkthrough, we're collecting data. I'm filling out a checklist. I'm taking screenshots. A lot of this we are getting permission up front to take the screenshots so we can use it in the report to kind of guide our recommendations, our education back to the family. And then if we do see something that's worrisome, the family's like, man, I smell, I have these things going on. We need to help you right away. These things cannot, go on any longer. So we have an opportunity to fill out. There's a referral survey called One Touch that I'll briefly mention later, but it's our ability to connect families to a variety of different resources by filling out a quick application. And it's all free, of course, to them. Everything that we're doing for the family is free to them just to let you know that. And so at the end of each of these visits, we provide some feedback to the family to let them know, what are the things that we saw that look, they look really good. Continue to encourage them to clean, whatnot, but also maybe there's some areas that need a little bit more attention. And we'll get into that a little bit more as we do the report, which is this next step. And so we do provide feedback nowadays virtually on the Healthy Home report. We call that the advisory plan. We're providing advice to them. We provide a very structured top 5 recommendations. Most of the time, I could probably come up with 10 or more, but we try to limit that. And we're looking at that exposure that could directly affect the child's health, which is kind of tricky sometimes. So, we're doing our best with that and understanding their health and their environment at the same time, and what we see during these virtual visits. And so during this, we talk about, additional education. Anita might provide, our health educator might provide some additional education on cleaning recipes. And, most of the time we're telling the families, you're doing a good job, as I mentioned. These are some steps to maybe address these situations. We're not going to tell them that, you have to stop using the bleach right now and not provide them reasons why. And so we always have a reason, why we suggest what we suggest. And then we also provide them with a Healthy Home kit, which you'll see here in a minute, actually right now. And so this is after that home advisory plan takes place. These are just some rough estimates of what it typically costs, $350 to $500 for a Healthy Home kit. That's changed since COVID a little bit with some of the costs. Whether, there's furnace filters that we provide, sort of greener, healthier cleaners that are not chlorine based. We do see a lot of families cooking their cleaning products on the stove because it smells good, or they're using mothballs in their vents because it smells good. So there's a lot of education around, why we're suggesting what we suggest over time. And then we do a lot of follow-up. A lot of this is, in some respects, some hand-holding and checking back in with the families. We do provide the ACT score that I mentioned, the asthma control test. That's called the asthma check survey. So there's a part of that within that survey that also talks about their home environment. And over time, of course, we want to see that positive change in the environment. We want their ACT score to go up. The higher it is, the more controlled their asthma is. So we want to see that they're, if they have any challenges, and how we can help them over time. So we'll do this follow-up a couple times, whether it's a virtual call or sometimes it's an email. Most families like the email these days. So as we're doing this virtual visit nowadays, we're trying to look at all these pieces to the home environment, whether it's the inside, the gas appliances, the outside of the home. I actually asked the family to take us outside if the weather's not too snowy or too cold. Maybe their baby's sleeping, so they can't go outside. But we do try to see the environment. One of the strengths, again, we'll talk about that as we go through here, is the families, they're looking at their environment differently than they ever have before. So I definitely feel like that is a way that we're providing that continued education about their home. So we look at it as a system, and we're trying to provide this education in a way that makes sense. We want to make sure that we keep our vents open and we use our exhaust fans because it helps pull out that humidity from those spaces that we're using time and time again. We talk about these 8 principles with each of the families and how a lot of these are interconnected throughout their home. If they have a leak, that may attract pests, that may make it unsafe. there may be some slip, trip, and fall concerns there. I mentioned this checklist that I fill out. This is a form of that. And so again, there's a lot of line items here, and so we again try to prioritize some of those concerns based off of our rating and scoring system that we have on this checklist. So as I mentioned, gas appliances, families might mention, I mentioned earlier about a gas leak. If, you know, maybe there's an open junction box or electrical box. A lot of families that we work with are renters. And so we do provide feedback in the form of landlord pages. And I always say that I'm happy to talk to the landlord about some of these issues. We do see quite a few code issues along the way as well. So these are just some common things that we talk about: chemicals and fragrances, you know, families using candles and incense, and they don't quite understand, you know, how that could be a concern for children that have asthma or sensitive individuals. Where are they keeping their cleaners? We talk a lot about that. We work with children under the age of 6 or 7 a lot, and so there can be risks of poisonings and some of those concerns as well. So this is just one example of a report as part of the feedback back to the family. We try to provide a lot of photos and information about, again, what was good and why we recommend what we recommend. Not that we just want you to stop using bleach. There are some additional alternatives to bleach if you are trying to clean up XYZ, whatever that is. And so each room that we assess has its own page. And so this is a guide over time for families to use as they live in their home on maybe what was addressed or what maybe routinely what they can address. And I know you saw the Healthy Home Kit earlier, but this kind of in stages is a multifaceted approach from doing the home visit, the virtual or even in-person visit, doing that visual assessment, understanding what those risks are, providing the Healthy Home Kit as an intervention along with the education, and then as dollars allow, we might be able to do some minor home repair to help address some of those exposure risks. And then we provide feedback back to the physician or medical team to let them know, you know, what we found and what the next steps are. Just some list of strengths and weaknesses. I can share this with John to send out if you all want, but I'm not going to read each of these, but I mentioned a few along the way. We definitely, there's a challenge with technology, to be honest, and the connectivity, seeing the home well, it doesn't always happen. And the differences between in-person and virtual, you know, we're not smelling those smells that we typically smell, but, you know, we're keeping each other safe too. So that's another positive with the virtual assessment. We're keeping our staff safe and we're also keeping the family safe. I mentioned the one-touch system. This is just a way, as I mentioned, to connect families to additional resources within our community, whether it's housing, basic needs, health. And then my boss, Kevin, our director, does a lot of teaching. He's actually teaching a course this week. And he provides 1 day up to 3 days of classes right now virtually, but he's working to move back in person here soon. And a lot of those will be at the Kansas City, Missouri Health Department. And as part of the course, most families will, or most students will get this book through BPI. As I mentioned, the KEEPA principles, that's a lot of this is centered around those as well. And that's my contact information and our website. Thanks for listening.
Well, thank you, Ryan. That's a really great program, and I appreciate your sharing it with us. The thing that I noticed is that you're collecting a lot of structured data. besides the report that you give to the family, what other kind of uses do you have for the data?
So as I mentioned, over the last 20 years, we've tried to put out reports, or I'm sorry, publications on the data that we've developed, that we've collected, whether it's particle data, looking at breathing zones for kids. Kids are younger, so they're shorter, they're breathing faster. So we're looking at the height differences of taking particle counts. So we're trying to put a lot of this data out there and to talk about sort of the practical sense of collecting data and what those uses are. So it's a challenge with a small group of ours and having the time to do that. But we have been fortunate to work with some of our statisticians at the hospital and others within our group.
Okay. Well, I have several questions, but I don't want to cut out the rest of the team. Are there questions from the group for Ryan?
Yeah, Ryan, I've got a quick question. I've got a little bit of experience in that space, bioburden space, and was just wondering if your group had seen an exacerbation during the pandemic of unintentional consequence of overuse of home-based cleaning products that impacted health.
So we do ask about cleaning. You may have seen that on the presentation and how often families are cleaning. We don't always know what they're cleaning with. We try to ask those questions. I still think it's more on the exposures with other particle-based items, so like the incense and the air fresheners. But that's a great question, because as you may imagine, with trying to make sure that whether they're cleaning their groceries at the beginning of the pandemic or disinfecting much more, we haven't really teased that out yet. But that's a great question.
Yeah, I can only imagine a quaternary ammonium with a chlorine type product with an asthma child. Not great combos, right? And we didn't get a lot of great guidance as a society on in the early stages on how to solve it.
Exactly. Yeah, a lot of what we tell families is, and maybe a lot of what you all know, is making sure those spaces are cleaned with warm soapy water first and then disinfect second. And families, even before the pandemic, they didn't quite get that, and I still see that with some of the families that we're working with.
Thank you.
Yeah, you're welcome.
Others?
Ryan, a great presentation. Thanks for sharing. Now you're collecting data. Have you ever tested the air quality with sensors in the home, or is it more of a visual?
So so this is just one example of a sensor.
Okay.
And we're not trying to promote certain devices. This is an AirThink device. There's so many different sensors that you can leave, or devices. It has multiple sensors in it.
Okay.
That look for humidity, temperature, carbon monoxide, particles, etc. Kevin and I are writing a paper with a group out of New York about sensors technology, and what's good, what's not so good, what's it telling families. I think the risk for, just to put this out there, for sort of just an everyday person going out and using one of these, they don't really know what the data is telling them. And so we do get that a lot, where, hey, can you review this report? What is this information telling me? So we started to use those over the last couple of years and doing more long-term sampling, because we feel like that's more, that gives us a better picture of what those potential exposures are. So we're still kind of teasing that out and seeing how good some of these sensors are. It's kind of hit and miss.
Yeah, thank you.
Yeah.
Ryan, one of the things that we think about is the topic of digital equity, and that is, how well are individual homes connected to the digital economy and the ability to reach out and interact with it. I imagine that a number of the homes that you interact with don't have good internet connectivity. Does that affect your virtual assessments, number one? And then number two, when they get a report, does that mean you have to send out a hard copy report to them?
Yes and yes.
Okay.
Yeah, more times than not, we do see those challenges. And we do have a hotspot now and some Surface Pros that we're going to start. And I know, John, you and I are going to talk about this, but going to start delivering to families to use in the homes. Just drop them off before the visit and see how that, see what that kind of looks like. So again, this is a free device, but the also benefit there too is they can fill out all those surveys that I was talking about right on the device. And so there's some time saving there. Plus it's a captive audience since it's kind of right in front of them. But yeah, the connectivity has been a huge challenge over time. And so I think that's one of the ways that we're trying to maneuver around it.
Okay. Any other questions from the group? I have kind of an oddball one, actually, Ryan, and that is the report that you upload to the medical record, does that get attached as a clinical note? Is that how that's represented to the physician?
So great question. Physicians, they honestly don't want to read a 20-page report, or our reports used to be 40 pages before we over time we've changed some things. So what I do now is provide that top 5 recommendations that I mentioned, issue an action plan that is basically a page and a half to their medical record. And so that goes back into each of the if they're part of the hospital, most of the time they are, not all kids are part of the hospital, but we do provide that feedback back into their record. So that, the physicians can provide the best care they can for the kids that we're serving.
Well, I'm sure it's very reinforcing as well. That's great.
Yeah.
Okay.
Ryan, I've got a question,
Please.
if you don't mind.
Yeah, go ahead.
Do you integrate your report into something like a My Chart? Are you familiar with My Chart?
Not well. It sounds familiar, but can you please describe what it is?
It's when you visit the doctor, they, summarize what they've said. Your prescriptions are on there. All the phone calls are on there. It's just kind of a communication portal.
Sure.
Thank you.
Yeah. No. That's a great question. So I don't know if we use Cerner. Cerner's set up the system long ago that we currently use. So it's sort of an attachment, if you will. It's kind of a interesting system, and everybody has their own level of accessibility to the system. It's all a little different depending on if you're a provider, social worker, me. So it looks a little different. But yeah, it can be difficult sometimes to find some of that information. But I do actually not only put it into their chart, but I email through the system to that referring physician, so they do have that information they can quickly review. But yeah, that's a great question. We're still trying to find better ways to get our information into the system, because we're pretty unique. I mean, we're not that clinical, right? I mean, we collect some health information, but so it's sometimes there's lots of questions like, well, why do you want that information in there? So we're still working on it. Great question, Todd.
Okay. Well, thanks very much, Ryan. We certainly appreciate your input here. It's great to see these programs advancing here in our own community and very innovative. So thank you.
Yeah, thanks for having me, John.
Let's transition here to really quite a different topic, and that's the ability to use augmented and virtual reality in neuroscience. And our presenter today is Dr. Sean Patel, who is a neuroscientist himself and a faculty member at Mass General and the Department of Neurology at Harvard Medical School. And his team is kind of a spin-off called REACT Neuro, and they have developed an ability to do neuro assessments using virtual reality equipment. And to me, it's very fascinating because we have sort of a silent storm going on with respect to in our health economy with respect to neurology and neurodegenerative diseases. And so this ability to actually do assessments thoroughly and unobtrusively is really seems to me to be a real opportunity. And we're very grateful for Dr. Patel to be with us today to show us that. So Dr. Patel, would you like to go ahead, please?
Thanks so much, John, and thanks for the invitation. It's super interesting. I've had the opportunity to chat with a number of members in the KC community, and it has been a breath of fresh air how you guys are thinking about implementing technologies to enable providing better healthcare, both in remote monitoring, remote therapy settings. So I'm super excited to hear about you and to learn about all the interesting work you guys are doing. John, can you just give me quick guidance here on how much time I should spend? Sorry, I think you're on mute.
You are correct, sorry. We have till the top of the hour, so please, I think maybe 15 to 20 minutes of presentation, and we'll use the rest for questions with you.
Fantastic. Okay, so maybe I'll share some slides here to give some visual models to what we've been up to. So as John alluded to, so I and our team really, I'll share here in a minute, come from a very academic background. We're a team of neuroscientists, physicians, engineers, entrepreneurs. And what we've done is kind of participated in this evolution, as we all have, as technology has matured, as our understanding of the brain has matured, as events like COVID have really brought top of mind the need to reimagine the way that we provide healthcare, make it more accessible, to democratize it. And as, again, John mentioned, neuro is one of these areas that has long been forgotten. In fact, even today, you know, forget about everything we've all gone through. You go to your annual physical, the doctor gives you all these numbers, your weight, your blood pressure, cholesterol, and you leave feeling healthy or not. And all those numbers really are telling you about your heart health. There's not a single thing for your brain. There's no checkup from the neck up, as one of my co-founders likes to say. And the reason for that is because, well, the heart is really important, but it does a very limited number of things. The brain, by comparison, has a lot of functions, very traditionally hard to measure. And this is really the problem that we have been solving. And so just briefly, we're a team of experts. We really have been thinking about this for a long time. One of our co-founders, Rudy Tanzi, is really leading the world in his research on Alzheimer's disease, having discovered the first genes and now really paving the way to introducing the first pharmacological therapies. And Brian here is an interesting background as a neurosurgeon, but also as an unaffiliated neurotrauma consultant employed by the NFL. And so a number of years ago, when the players Association lawsuit against the NFL, one of the outcomes of that was there should be an unaffiliated doctor at each home game. And so Brian is the UNC for Gillette Stadium here. And don't hold that against us, but we're Patriots fans out here. And the funny thing here is actually the company started really through a conversation with Bill Belichick, the head coach of the Patriots. So Rudy is one of the brain health advisors to the team. And in one of his conversations, Bill noted that when a player took an injury for whom he deeply cares about, the best current standard of care is somebody would come and do this kind of moving finger test, follow my finger. And to him, that observation was highly rudimentary and uncertain. And Brian would be the first to agree because he's the one administering these tests. And so he asked if there is a better way. What we did is we assembled a team of really talented virtual reality developers and machine learning scientists and built a board of industry experts from John Brownstein, the Chief Innovation Officer here at Boston Children's, to digital health experts at payers like Humana and David Icke, to pharma like John Reichert, and to rehab like Ross Safan. And we instilled deep expertise from clinicians that have been studying VR in their specific domains, whether it be assessing head injury in warfighters, the Naval Special Warfare Group, or to enhance performance in college and professional athletes in the US Olympics, like the work Gary Wilkerson is doing, to general neurocognitive assessments to deal with this underlying pandemic in and of itself, which is neurocognitive decline and Alzheimer's and dementia-related issues. And the notion here really stemmed from the observation that, things like, and I'm better for worse, I wear these things. I have an Apple Watch and it tracks all of my metrics. And it's really quite remarkable the extent to which these technologies have permeated our culture. The idea that everyone nearly understands the idea of 10,000 steps a day is really just kind of outrageous. They know that taking these steps has some correlation to improving our cardiovascular risk factors. And that's been the culmination of decades of research in biomarkers, cardiovascular biomarkers, relating to predictive longevity outcomes. The same exact thing is true for your brain. It's just that we don't have the spotlight to elucidate these numbers, to track these longitudinal measures. And that's really what we have developed at REACT. And again, as I mentioned, the reason for this is because, well, the heart does some very important things, but they're limited in scope as compared with the brain. Even today, no matter where you are in the world, the best hospitals or in the middle of the wilderness, access to assessing your brain is highly limited. It involves scheduling an appointment with a specialist, which typically has a 6 to 9 month wait list. And when you get there on that day, it's a 7 to 9 hour day. They print out a stack of papers, and each of these papers is some form of a neuropsychological test that measures one of these dimensions of cognitive functions that your brain can do. And of course, the challenge here is that they're highly subjective, they are rudimentary, they're hard to quantify, they're hard to track over time, and access is extremely limited. And that's where this observation came in a number of years ago. So virtual reality has been developed as the world's best gaming platform. But from our perspective, what this is the world's best mobile laboratory. This is the best brain-machine interface that exists. It delivers information to your brain in exactly the way your brain has developed to perceive it. So much so, in fact, that if you go on YouTube and type in VR, you'll often find really funny videos of people standing on a conference room floor, literally their feet on the ground. They're in a big environment, noisy, knowing that people are right next to them. They put the VR headset on, all of a sudden you're 20 floors up, walking out of an elevator to down a plank, and somebody, their friend typically gives them a little nudge and they fall to the ground. Your brain processes these sensory inputs to form its perception around the world. And even though you know you're standing on that conference room floor, the second that visual information gives you the perception of being 20 stories up and walking off of a building, your brain can't control it. And so if you can leverage this technology and design software that can be used to leverage this to assess and to treat the constellation of neurological symptoms that we express throughout our life from childhood to late adulthood, you now have a tool that can democratize access to the world's best care, a blood pressure cuff for the brain. The way that we do this is we use deep and rich sensors built into these headsets these days. Specifically, we use high-speed eye tracking of both eyes, voice, and movement, 6 degrees of freedom, sub-millimeter accuracy that these headsets provide, combined with our deep understanding of neural circuit function and machine learning to do what Apple Watches and Fitbits and the wide number of wearable devices that exist do for our heart, but for our brain. And the vision here is to do this such that it can democratize access to the world's best care from the comfort of your home through this single technology platform, and to make it as simple and proactive as heart health is today. So this is what our platform looks like. We're a software. We run on off-the-shelf hardware, and we're hardware agnostic. So we have a partnership with Pico. Pico is one of Qualcomm's portfolio companies and is the enterprise VR headset competing with Oculus. And the thing that I mentioned here that I'd like to highlight is that in order for this to really work, you have to kind of solve the problem. This is not just a one-trick pony. And this was a kind of fundamental constraint for us even to have started this in the first place, was that because we saw this opportunity that VR could be this democratization tool for brain health, not just for assessment, but also, and most importantly, for therapy. And if you could deliver that through a very modern, easy to use interface, then you have the basis of something that can be scalable and engaging. And I'll just share a little bit about what we've been up to. So we have developed on the assessment side. So these are digital exams, as we call them. Each one of these is a short 30 to a minute and a half VR experience. It's self-guided through a coach in the VR headset. Teaches you about what the exams are intended to assess, how to play the exams, and then to run the exams themselves. And we do this for a constellation of neurocognitive functions, both higher order cognitive processes that we all likely think of when we think of our brain, like memory and attention and processing speed, to things that we might not think of traditionally, the reflexes of our brain, eye and head movements. These are much more important in the setting of injury, but as we've seen, can be very predictive for neurocognitive decline as well, to mood, to balance and performance. But these are all the wide variety of things your brain can do. And today we've built 25 of these digital exams, developing the world's most comprehensive digital assessment platform. And we started with this idea of a general neurocognitive assessment. So this is really like what Fitbit did in the early days, is just telling you how many steps you've taken. What we're doing here is telling you how all the variety of things your brain can do are functioning, and to allow you to track those over time. And we've been at it very luckily with some amazing partners for about 2 years. When we started on this journey, we found an opportunity with senior living providers across the United States. And we have about 1,000 users using the platform over the last 2 years on a bi-weekly to monthly basis. And we've collected now, this is a little out of date, but more than 40,000 exams across these individuals longitudinally. And this has been an incredibly rich data set because for these individuals, we also have their EHR data, which allows us to understand their diagnoses, any medication they might taking, as well as the current standard of care assessments, these paper-based assessments that I described earlier. And this has really allowed us to uncover a great wealth of knowledge in predicting early cognitive decline. One of the things we've seen very readily and now implementing into the product as for our senior living customers is these paper-based assessments have pretty low sensitivity. So often you can have a nearly perfect score where you're having underlying cognitive changes that are consistent and declining. The reason why this is so important is because just like for our heart, changes in our lifestyle, nutrition, wellness, exercise have dramatic and meaningful effects on our health if we know to intervene and if we're able to track those in order to reinforce those signals in real time. Also, it's important to be able to detect these early changes to raise alertness, getting your clinical team and family members aligned on your health in advance proactively, rather than waiting till you're becoming forgetful or experiencing falls, which unfortunately lead to precipitous outcomes. And the way we do this, so initially we started out as building this technology, and it took us quite a long time to build this technology and develop these algorithms. And then we took a beat and some inspiration from some of the other companies in the space like Peloton and Tonal and all these connected health equipment manufacturers that are dealing with the underlying same problem as applied to exercise. So how do you get individuals out in the world to get excited about exercising? And it's one of these unusual things where there's a high activation energy, but often you'll find that once you start, you know, you're feeling good and it's easy and you think momentarily is like, oh, I could do this. Like, well, why haven't I been doing this? And then the next day again, it's like, I'm feeling too tired, or maybe I'll do it tomorrow. It's that activation energy. And they solve this problem by changing the way you deliver this knowledge, but also engage with the users by creating personas. And for them, they were coaches. And these coaches are like mini celebrities in their own right. People have almost religious experiences with these individuals because they are speaking to them in a way that resonates and gets them excited and lowers that activation energy and continues that engagement. And so what we have done is wrapped these digital exams and digital therapeutics that we have developed into programs, much like you might do an ab blaster program with your connected gym equipment. We would have programs related to the variety of things that we deal with neurologically. The first one we've built is what we call the REACT baseline, really geared towards seniors. And this would be that kind of annual or biannual comprehensive exams so that you can be proactive in your care. And what we've done is we've identified REACT brain health coaches, these exemplar, highest quality clinical, amazing clinicians, but optimized for engagement, building rapport, and creating connections. So these are the clinicians that we all wish we had when we are both well and sick. And we deliver this through this immersive, enriched, and engaging VR experience that allows the clinicians to handhold users through the experience, educating them around what all these things are about the brain, because we learned that this was a big gap in knowledge. Yes, 2 years ago, everyone was jumping over the moon to be able to assess their brain. But as soon as you provided these metrics, you know, it was simple questions like, what is processing speed? Why is it important? What can I do about it? And as a neuroscientist, like, these are things that we know all very well, but in order to communicate this to the world at scale, we have to also educate them in a way that's accessible and that is interpretable and that is engaging, inspirational, and informative. And that's what we've managed to create. I'll just give you a quick example for the sake of time. So I'll just show you one simple exam that we have. It's called the trail making test. And this is based off of a current standard of care assessment. And what you'll see here in this short little video clip is how the current standard of care is done. It's a sheet of paper and you'll see a series of numbers. And all you're asked to do is take a pencil and draw a trail starting at the number 1 in ascending order, 2, 3, 4, 5, and so on until you've completed. And typically what a clinician would measure using a stopwatch is how long does it take to complete the exam. What we've done is we've leveraged the power of VR and of course eye tracking, voice, and or machine learning to amplify these signals. We've implemented a similar version in VR, you'll see here in a second, where you'll see the series of constellations in virtual space. Rather than a pencil, you'll use your controller and it'll be kind of like a laser pointer and you're making these movements. But what you can't do on the traditional test is you don't know how people are actually solving the problem. So how long does it actually take for them to find the next correct target? Once they find that next correct target, the brain has all the information to begin to execute the movement. How long does it take for them to actually then execute the movement once they've seen the target? That tells you how your brain is actually processing this information, controlling for attentional or visual spatial issues. And then once you start executing it, what's the quality of the execution? Is it really a straight movement? Do you have a tremor because you might have underlying Parkinson's disease and there's a vibration, or perhaps you have arthritis, or perhaps you take a long and circuitous route, which is indirect. All of these things and many, many more we're able to capture, creating thousands and thousands of digital biomarkers from this simple 30-second test. And this is just one of the 25. Let me give you a quick example of what it looks like.
Like trail making, where you draw a trail from the number 1 to 2 to 3, and so on.
So we have this exam, and I'll just give you one example of an individual from the thousands of users that we've had. So on the left here, this is one of our senior living users. I describe him as a power user. He would use REACT on almost a daily basis. So we had quite a lot of data from this particular individual. And on this test, what you see are the results from the trail making exam. So on the top, you see the actual trace. We also use the eye movements that are presented here as well. And you can see that though it is a little squiggly, which is different from what a healthy, normal individual would be like, you can see that the individual is doing this test quite readily and is able to complete. On the bottom graph, if you can see my mouse, you can see that he's getting them correct with very few of these X's, which would be incorrect markers. And this was on May 27th. Again, we have huge data in between May and October, and you can see there's a linear progression here to where he ended up on October 7th. And not too far after this, he was diagnosed with Alzheimer's disease, and then his current care changed. And what we can see from our exams is that these signals lead these changes by many months and sometimes even years. And the ability to track these things allows you to have a window, an opportunity to proactively change your health and wellness. One of the largest studies in the world, it's called the Finger Study, hundreds of thousands of individuals over many, many years, randomized, double-blinded, placebo-controlled study showing that adherence to meaningful health, wellness, and exercise changes could be disease modifying, even with people, for people with MCI, which is the stage before developing Alzheimer's disease. And so these dramatically beat any effect sizes from any drugs. Like, it's kind of laughable that we're all sitting and the New York Times headlines are about Biogen's Aduhelm drug and the controversy therein. Whereas the answer is literally right in front of us. It's free and accessible. It's just that our own human behavior and psychology limits us. So the question is, how can we use data and digital tools to enlighten us, to enable us to see this so that there's no uncertainty as to what's happening, and then use this technology to inspire us, to engage us, to motivate us, much like Peloton and others have done to change our wellness and health. What we've done in this is not only do we have these exams and these therapies, but we've developed and deployed over 100 different visual experiences in 360 as well. And again, this really came from our learning with senior living. Is you have individuals that are in essentially a captive environment, and that in and of itself is a huge desert for your brain. You think of children, it's like they're inquisitive and explorative and novelty seeking, and you're going and moving around, and your brain thirsts for these types of experiences. And it remains so as we get older, yet for some reason we do this often less and less. Virtual reality is an amazing technology that allows us to kind of re-deliver this inquisitiveness. And so we've partnered with places like the Berklee School of Music here in Boston, the best music school in the country, and recorded music from a number of different decades and a number of different styles in a number of different languages that people can explore, to visual experiences and travel experiences and learning experiences and more. These supplement the exams and therapeutics. Of course, these exams also lead to diagnostic opportunities. So one of the key advantages of our platform, it's literally the same platform that's used for senior living, that's used with our professional sports teams, it's used with our military partners across the whole entire spectrum. And as we've been doing this, we've found all sorts of opportunities to better improve, dramatically improve the way we might screen for diseases like Alzheimer's, or to diagnose or treat or quantify a return to work metric in the setting of a head injury, and much more. And so we have a number of these clinical trials underway right now with our platform to enable these to the marketplace. That's the diagnostic side. And again, the important piece here is that it's not just the blood pressure cuff, right? So the blood pressure cuff in and of itself, not particularly important, though I would argue it's one of the most marvelous innovations in history. It's this device that doesn't use any battery, which is rare today, and measures this really complicated system, your vascular system, and even allows you to separate the systolic and diastolic pressures in your heart. And when it was first invented, you'd probably wonder, what can I do with this? Yet this technology enabled us to understand that when you have high blood pressure, it leads to poor cardiovascular outcomes in the long term. It had allowed us to enable us to understand that when you give certain drugs like a statin, it reduces the blood pressure. And that creates opportunities to deliver therapy like statins to improve the way we live and how we age. The same is true for our brain. So we've done quite a lot of work in human performance with a number of college teams, basketball and football at the elite level, taking the same technology and helping them to improve in aspects of performance. We've even been able to predict pre-season who would experience a lower extremity foot or ankle sprain, or who would experience a concussion based on slight differences in their neuromotor skills. And what's really important is that these can be improved and trained through the REACT experience. One of the areas I'll share briefly here is on our stroke neurorehabilitation program. So we're undergoing a clinical trial at Kaiser Permanente and discussing with the stroke folks at KU right now to participate as well. Stroke is one of these really challenging disorders that leads to pretty poor long-term outcomes. There are a number of reasons why these are poor, but one of the kind of most basic is access to physical therapy. Socioeconomic factors limit our ability to get to the PT on a twice weekly basis. And even if you were able to get there, 2 hours in a week is a limited amount of time to to get therapy. And this is what it might look like. And you'll notice here is that this is a form of physical therapy where the patient is to try to grab and lift this can and place it on another. And unfortunately, what happens, this is very common, is that there's no reward, there's no feedback mechanism here. Of course, he's not able to do this. It's quite a complicated task. And, this is in some progress of his therapy, but ultimately the physical therapist ends up kind of doing this motion for him. What would be ideal is if you could have a system that could dynamically scale to your level of ability and to kind of change that level of ability in the background over time. And so one of the therapeutics we've developed, we have this immersive VR game experience. So it's a large story arc set in this virtual resort called Crystal Cove. And as you go through your check-in and you go to the gym and you get baseline and you go to your room and you have access to a number of these different games, you'll see these games are all developed to rehabilitate very specific movement of upper limb, things like movement to mouth and grasp, in a way that's continuously engaging for the users, despite their level of motor impairment. And so here you'll see the user reaches for the ball, it automatically loads into the cannon, they point using their head and it shoots the cannon. So there's a goal-directed behavior. What you don't see here is that in this particular case, if your range of motion is limited, the virtual environment, the physical world, is controlled by the computer. And so we can give you the sense of actually reaching out and grabbing this, which is highly motivating to see for your brain. And what the user will experience is a slight increase in difficulty every single time they do this. And so of course, those neuromotor circuits get reinforced. And because it's separate from the real world, it's the virtual representation, they have a much greater, much more engaging experience. And of course, all of that can be delivered through the comfort of your home, to attract and to be connected with your clinical care. And lastly, I'll just leave off is that this is all wrapped in kind of what we expect now as modern technology users and a high quality user experience and mobile and iPad and HIPAA compliant web apps to allow for the digital technology to interface and to communicate directly with you in a highly efficient manner. So I'll leave it there. Sorry that it went a little long, but glad to have any feedback or to answer any questions.
That's great, Sean. Thank you very much. I guess one of the things I like is that the analytical part of it, that so often we think of AR and VR as stepping out into another world, whereas in a way the world is also looking at, in this REACT Neuro scenario, it's kind of looking into us as well. So that bidirectional aspect is something that's not really seen in this space, and it makes it very interesting to me. Others, comments or questions?
Is there any particular symmetrical speeds that you need and latency and jitter and other requirements that you would like to have in order to get the optimal experience in the home or in caregiving situations?
Do you mean from a network infrastructure perspective?
Yeah.
Yeah, so I think this is a common and shared theme amongst the conversations we've had is like, we started again 2 years ago and we started in senior living communities. And of course, these communities all had varying levels of connectivity. And that was quite a hard lesson to learn. Also, when we're working with the Department of Defense, they of course do not want any network connectivity. And so we've managed to develop our system to work in both scenarios. It is benefited by having connectivity. We've developed some compression methods to be able to upload these data packets remotely and quickly when able and when connected. But these are all kind of stopgaps, I imagine, the world and hardware manufacturers are really thinking deeply about how to integrate high bandwidth connections into these tools and headsets. Hotspots are definitely a temporary solution for this as well, for more remote environments, and we've used those in certain use cases. These are really important, but as a young startup, we have been very careful to stay away from problems that we're not best suited to solve. And since we know that the industry is really focused on these things, we're eagerly looking to see how these solutions manifest and how we can leverage them.
Okay. Are you working with anyone at Xfinity or Comcast locally?
No, we are not.
Okay. I think you'd be an interesting conversation for somebody with them and our group, and also with the virtual reality group. So I'll get in touch with them and let you know.
Yeah, I was talking to John and Doug as well, is that the infrastructure is a pivotal barrier to delivering these technologies. And I think that is, and people realize this, but I think it's understated, is that these technologies, we can deliver the world's best care. I mean, we work with the world's best clinicians, and bi-weekly their heads are blowing based on the kind of data we're getting, is that they can't do this in the hospital, in the world's best hospital. And now all of a sudden you can do this in your home. It's not a compromise. It's in fact better than anything you can get, but it's limited by, do you have an internet connection that can withstand it?
Yeah. Okay. Thanks.
Others, we have one more minute, but we can go over a little bit if necessary. So if you have a question, please share it with us.
Yeah, Dr. Patel, thank you for the presentation and the information. Just curious, I saw on your board of advisory, you had somebody from Humana. Do you find that the insurance companies are starting to recognize the democratization that you described and the value of the information, thus compensation for it?
Yeah, it's a really interesting question. The whole digital health landscape is a bit of a quagmire at this moment in time. Everyone's trying to learn how to operate and to leverage these technologies. And there are a number of large and new entrants, even outside of the traditional payers, that are participating. Even companies like Walmart and Best Buy and CVS and Walgreens are leveraging their brick and mortar fingerprints to capture this. Payers certainly have a really motivating perspective in that if they can leverage these technologies and reduce costs, that's very meaningful. Stroke is a $34 billion a year Medicare budget item, and that would be fine if the outcomes were great, but we all know they're not. And so how do we leverage technology? And this is kind of like the low-hanging fruit. This is just connecting the dots of what where society has gotten us today in terms of our understanding of the brain and in terms of technology and access. If we can just connect them in meaningful ways, we can really reduce costs. And I think that's why Humana is really leading the way in terms of at-home monitoring and therapy, and Kaiser is a payer provider for whom these types of things are really important. I think a lot of them are thinking this way, but it's still early to figure out how this all manifests in the world.
Thank you.
I want to thank you for your presentation, Dr. Patel. It was really fascinating, and I applaud you for the work that you're doing. I just wanted to quickly ask, just out of my curiosity, who is your ideal market? Who are you targeting? I know that you said that you worked with senior living homes in the beginning. Have you kind of changed direction, or where are you headed there?
No, so it's important to think for us that our vision is to create this as a platform that is accessible to everyone. And the reason why that's so important is because that's fundamentally the enabling nature of the headset and the software. Now, how do we get from there as a early stage company to get there? Senior living has been an incredible beachhead because it is the subset of all of us for whom these types of issues are top of mind. They're in a stage of life where cognitive decline is really a real life experience that can happen, and we're in a point in our life where we understand we can be proactive about these changes, yet no technologies exist there. So we are really focused. In fact, we just kind of, this past week, we've kind of come out of stealth and we're pushing forward now in the senior living market. But at the same time, we have a number of other clinical trials that are underway to enable this vision. And because a lot of this will be enabled through real diagnostic and real therapeutic claims, and we want to be able to provide this kind of validation and quality to users, we really want to be able to provide a tool. It's literally exactly the same tool in a non-regulated manner as a way of tracking and measuring your metrics over time, but then with clinical trials and validation of our algorithms, be able to provide that same tool with more diagnostic and therapeutic claims. And so we're really focused on senior living and performance because they're non-regulated. It's literally leveraging the same technology. And as our regulatory approvals for our concussion diagnostic, our stroke therapeutic, our Alzheimer's diagnostic get completed over the next 12 to 24 months, they will enable and be wrapped up. And the way we view this is as like a Netflix subscription, but for brain health, is rather than having just the REACT programmatic baseline, as more and more of these become available, we'll have things related to stress or ADHD or cognitive decline and Alzheimer's, stroke and concussion. And eventually you can have one device, one headset for your house, and it will serve everyone from the teenager to late adulthood for all the variety of things you might experience related to your brain from the comfort of your home.
Fascinating. Thank you.
Yeah, great, Sean. Steve Kropp.
Yeah, like the rest, really appreciate the work you're doing on this. I saw a presentation a few years back, and it was related to PTSD treatment and some of the things that you're doing, for stroke patients. They're using it for some of the, armed services members who have had PTSD. Do you see this working, like even in children? I think, from the PTSD treatment that they have, how to use this ABR in a way to bring that about. So I guess my question is, how far are you pushing the boundaries beyond stroke and other areas that would really appreciate the value of this?
Yeah, so I mean, we fundamentally designed this in a way to treat all variety of things brain health related. The reason for this is that this, the structure of the problem, i.e. the brain, is that it does so many things. But we can't have like 20 products. We can't have one product for one thing of the brain and another product, because then you don't get democratization. Costs remain high, user experience remains varied. If you have one product that can do all of these things, it's the amplification, right? So it's when you're building the hardware and software, you can create the best user experience and then to give one singular entry. What we're doing is we're really focusing on 3 areas in our current stage of development. Again, we're a small company, less than 20 people, and that is on general neurocognitive assessment, concussion, sports enhancement, and stroke. But that being said, we do these clinical studies with our partners. So for example, with PTSD, that's a big one. And we have a really strong program with our warfighters. So here at MGH, there's an organization called Home Base, which is a joint collaboration between the Department of Defense and MGH. They built a hospital there, and they send all their special operators who get injured there for a period of time to undergo a systematic and detailed analysis. And of course, PTSD is an extremely common and important neurological issue to deal with, especially in the setting of concussion. And so we are working actively on applying the technology to be able to discriminate those and to further create better clinical outcomes for warfighters after they've sustained an injury.
Well, I think we're probably going to have to sign it off there, but that was a very high note on which to do so. So thank you very much. I thought that was really outstanding. we look forward to seeing you back in the Kansas City environment, Dr. Patel. It'd be very interesting to see what can be done here in our area, and we appreciate your guidance in bringing us kind of up to date on these new and emerging technologies.
Yes, thanks so much for the invitation. It's truly been a pleasure to get to know, and I look forward to meeting more of you guys and seeing if we can work together in any way.
Great. I'll just stop a recording here.